All right, diving right in today, chest wall, anatomy, wounds, the whole reconstruction picture. And we're aiming this one squarely at FRCS plastic surgery exam prep.
Exactly. Cut through the noise, get to those high-yield points. We're pulling this straight from your core surgical text, those anatomy Bibles you're poring over.
Efficient and targeted. Love it. So, mission for this deep dive, make your revision razor sharp, laser focused on exactly what the examiners want to see.
Couldn't have put it better myself. Let's start with the pleural cavity, those two layers. Visceral pleura, parietal pleura.
Okay, pleural cavity. And I remember this tripped me up initially. They come from different embryologic origins. Why is that so crucial? For the exam, I mean.
Because it explains why they behave so differently, right?
Yeah.
Different blood supply, different drainage veins, lymphatics, even their nerve supply is separate.
So it's not just a random anatomical fact.
Not at all. Think about it. Infection in one layer doesn't necessarily mean the other's involved. Or how you approach surgery in the chest, you have to respect those separate origins. It all comes back to that.
Got it. Separate origins, separate implications. Okay, on to the thoracic skeleton itself. I mean, it's a cage, sure, but it's more than that.
Way more. Obviously, stable support for everything inside, huge protection factor, not just for the heart and lungs. Great vessels, even some upper abdominal organs get tucked in under there.
Right. But then there's respiration too, right?
Absolutely. Can't breathe without that thoracic cage expanding and contracting. And then, don't forget, it provides support for the upper limbs as well. A lot going on there.
Let's break down the structure. 12 pairs of ribs. First up, those true ribs.
So those are ribs 1 through 7. Sometimes we consider 8 a true rib as well. They articulate directly with the sternum, each one via its own costal cartilage. Vertebrosternal. Nice, neat, and direct.
Then we have the false ribs, 8 through 12, more of a shared connection.
Exactly. They're vertebrochondral, meaning they connect indirectly. They attach to the costal cartilage of the rib above.
And then our free agents, the floating ribs, 11 and 12.
No sternal connection whatsoever. Just those two, hanging out posteriorly, articulating only with their corresponding vertebrae.
All right, sternum time. Roughly 15 to 20 centimeters long, divided into 3.
Top down, you've got the manubrium first. It's that wider, thicker portion at the top. Articulates with those clavicles we mentioned and with the first costal cartilage.
Key landmarks on the manubrium.
Well, got to know the angle of Louis. Clinically, super important. Marks the junction between the manubrium and the body of the sternum. And that's at the level of the second rib. Helps you orient yourself on a physical exam.
Below that, the body of the sternum, the long part.
Yep, longest part. Sits right there, anterior to the 5th through 9th thoracic vertebrae. Pretty straightforward.
And then that little tip at the bottom, the xiphoid process.
Smallest, most variable of the 3. And remember, it usually ossifies and fuses with the body of the sternum by the time someone's about 40 years old. So it can be a palpable landmark, but be aware that it can vary quite a bit from person to person. And just to round out the bony picture, those clavicles and thoracic vertebrae are key parts of the structure too, even if we're not getting into their specifics right now.
Right, bony framework sorted. Now let's layer on those thoracic soft tissues, all that muscle, subcutaneous tissue, and skin on top of that bony cage. What are our key players, muscle-wise, for respiration, exam gold, this stuff?
Absolutely. Well, the diaphragm, that's our primary mover, no question. And then you've got your intercostal muscles, 3 layers.
Yeah.
External, internal, innermost.
Intercostal muscles. Now, where those neurovascular bundles run, that's got to be memorized. Right?
Oh, absolutely high yield. Between the internal and innermost intercostals, posterior to the costal groove, tucked under the lower edge of each rib. And the order vein, artery, nerve, van. Remember that.
Vein, artery, nerve. Okay, got it. But tricky because they don't stay in exactly the same spot, do they?
Right. You've got to picture it 3-dimensionally. So anteriorly, those intercostal spaces are wider and the bundles are more central. As you move posteriorly, they shift a bit closer to the rib above.
Okay, so location and spacing change a little bit depending on where you are in the chest. Beyond the diaphragm and intercostals, what other muscles kick in for breathing?
Well, those are our primary workhorses.
Okay.
But in a pinch, you've got your accessory muscles, sternocleidomastoid, scalenes, and then posteriorly, the serratus posterior, superior, and inferior, levators costorum, they become more important when someone's in respiratory distress.
And then, of course, all those muscles attaching the upper limbs to the thorax, how do they factor in?
So superficially, you've got your pec major and minor, trapezius, latissimus dorsi. Deeper, you've got serratus anterior and posterior, levators costorum again, and the rhomboids. And clinically, here's something to think about. When someone's really struggling to breathe, They might actually use their pec major and serratus anterior as accessory respiratory muscles.
By bracing their shoulders.
Exactly. Stabilizing that shoulder girdle helps them use those muscles to assist with breathing. It's a sign of significant respiratory distress.
Makes sense when you see it in a patient. Okay, internal mammary vessels. They're not always the go-to for reconstruction, but we need to know them.
Yeah, not your first thought for chest wall itself. But they're potential recipient vessels for microvascular free flaps. So for those really complex cases, you need to know their quirks.
And there are a few quirks. I remember Shaw's study showing they weren't so reliable down at the fifth intercostal space.
Yeah, 42% unsuitable down there. And then Clark's group added more detail about size and branching patterns. Basically, as you go lower, those vessels get smaller and tend to branch more. Below the fourth intercostal space, things get less predictable.
The higher is better.
Seems so. Third intercostal space was their sweet spot. They even noted differences between the left and right sides, vein diameter, and all that. So even if you're not using them for chest wall directly, knowing their anatomy is critical for planning those complex free flap reconstructions.
Right. Always good to have options. All right, let's shift gears. Chest wounds. What are we looking at cause-wise for the exam?
Broad categories: trauma, tumor resection, infection, radiation damage, congenital issues. If you can categorize a chest wound, you're halfway there.
All right, patient walks in with a chest wound. Evaluation time. What are those absolute must-ask, must-examine things?
History is king. Absolutely have to dig into their respiratory history. Underlying lung disease, pre-op PFTs are your best friend there, tell you how much breathing reserve they've got, and then detailed surgical history. Previous thoracotomy, subcostal incisions, axillary dissections, CABG with IMA harvest, all those can completely change your reconstruction game plan.
Because of potential donor sites.
Exactly. Latissimus dorsi, serratus, rectus abdominis, pec major, depending on what's been done before, those might be off the table. Don't forget to check those old operative notes, and imaging is your friend, CTA, MRA, whatever you need to get a clear picture.
And the physical exam itself, what are those red flags, things you're specifically looking for?
Think about those congenital conditions that'll impact reconstruction. Poland syndrome, for example, that absent pec major latissimus can change your approach. Or any pectus deformities, previous interventions there could affect those vascular pedicles you're relying on. Subtle stuff, but it matters.
So we've got our wound, we've assessed the patient. What are we aiming for? What are the big goals of chest wall reconstruction?
Number one, always aggressive, thorough debridement. Get rid of any dead tissue, any foreign material. That's your foundation for success. You need that healthy wound bed.
Then the reconstruction itself. When do we need to worry about bony stability?
If you've taken out more than 4 ribs in a row, or if the defect is bigger than 5 centimeters, you've got to think about skeletal support. That's crucial for breathing mechanics, protecting those vital organs underneath. And of course, you want to obliterate any dead space to prevent infection.
In coverage?
Got to have durable, well-vascularized, soft tissue coverage. Living tissue is key for fighting infection, filling that dead space, and supporting your repair. And of course, you're always aiming for the best aesthetic outcome you can achieve. It's a lot to juggle, but that early, aggressive debridement can't overstate how important that is.
Now let's get into some specific scenarios. Pleural cavity defects. What usually causes those?
Most common scenario. Complications from lung or esophageal tumor resections can lead to bronchopleural fistulas, tracheoesophageal fistulas, serious stuff, high morbidity, high mortality.
So what's the goal when you're dealing with a pleural cavity defect?
2 things. Get rid of that infection and create an airtight seal in that pleural space. No leaks allowed.
How do you actually achieve that? What are your tools?
Local muscle flaps are your workhorses here. Latissimus dorsi, serratus anterior, pec major, rectus abdominis. The omentum can also be a great option. Usually you're accessing this through the previous thoracotomy incision, or you might need a separate incision. And one key point, technically you got to avoid any kinking or twisting of that flat pedicle. Blood supply is everything.
Okay, on to bony reconstruction. What are the main causes of those skeletal defects?
Infection after cardiac surgery is a big one, especially those sternotomy wound infections. Potentially life-threatening, and more common if the internal mammary artery was harvested for the bypass. Then, of course, you've got your tumor resections, trauma, radiation necrosis. All those can lead to skeletal defects.
You mentioned those sternotomy infections. There are classifications for those, right? Worth brushing up on for the exam.
Absolutely. Yeah. Parallel is 1. Type 1, just some serious drainage, culture's negative. Type 2, full-blown purulent mediastinitis within 3 weeks. Type 3, that chronic draining sinus. Then you've got the Starzinski classification, which looks at the extent of the bony defect and how it impacts the patient functionally. Know those for the exam.
And just to reiterate, when do we actually need to reconstruct the bony chest wall? What are our indications?
If you've resected more than 4 ribs in a row, or the defect is bigger than 5 centimeters, you're probably looking at reconstruction. And even with smaller defects, if the patient has underlying lung disease, you might need to reconstruct for stability. Now, there are exceptions.
Like what?
Well, if there's been significant prior radiotherapy to the chest, that can actually stiffen the chest wall enough that you might not need to reconstruct a larger defect. And those posterior superior defects, the ones tucked up under the scapula, sometimes you can get away with leaving those a bit bigger because they're more protected.
So it's not just size, it's the whole picture. And what are our options for bony reconstruction, both alloplastic and autogenous?
Exactly. Alloplastic, you've got your mesh polypropylene as your workhorse, strong stuff. EPTFE is another option. Might have less tissue ingrowth, which can be good or bad depending on the situation. Methyl methacrylate, that's your rigid option, but higher infection risk. A cellular dermal matrix, good for lower infection rates, but you might see more seromas. And then titanium plates. Those are great for transverse stability, and they allow for early mobilization.
And the autogenous options, that's our muscle flap territory, right?
Yep. Local regional flaps, your go-to. Pec major is great, reliable turnover flap. Latissimus dorsi, big workhorse, good for large defects. Rectus abdominis, good volume, can be versatile. Serratus anterior, omentum, those can come in handy too. And don't forget about VAC therapy. That can be a great bridge to definitive closure.
So lots of options depending on the defect. Now, what about soft tissue reconstruction, separate from bony issues, I mean?
Right. So if it's just partial thickness loss, you might be able to get away with a split thickness skin graft, assuming the wound bed is well vascularized. Or a local skin flap could do the trick. But if you've got full thickness loss, you're usually looking at a local regional muscle flap. And for those really big defects, you might need to bring in a free flap.
Location matters too, right? Different areas, different flap choices.
Absolutely. Anterior chest, mediastinum, you're thinking pec major, latissimus dorsi, omentum, rectus. Anterolateral chest wall, you've got latissimus again, omentum, rectus, external oblique, serratus anterior. Even that transverse thoracoabdominal flap can be an option. And for diaphragmatic defects, if it's small, you might be able to just suture it directly. But for larger ones, you're looking at things like a cellular dermal matrix, mesh, depithelialized tram, that's where you remove the skin, and just use the fat and muscle for bulk latissimus or omentum.
What about those really tough cases, chronic empyema, bronchopleural fistula? Those can be tricky.
Yeah, those are real challenges. LOS or flap is an option, but it just provides drainage, doesn't actually address the fistula. Thoracoplasty can be effective. Yeah. Collapses the chest wall to obliterate the space, but you're causing some deformity, potential shoulder problems, and then muscle flap omentum, rectus, latissimus. Those can be great for obliterating space. Sometimes you can even use a depithelialized fasciocutaneous flap for added bulk. And for those really complex, large defects, you might need to go with a free tissue transfer.
Okay, last but not least, chest wall deformities. Mostly we're talking about cosmetic issues here, right?
For the most part, yeah. They usually don't have a huge impact on breathing or heart function.
Yeah.
It's more about appearance and quality of life.
Poland syndrome, that's a classic.
Yeah, relatively rare.
Mm-hmm.
Incidence is something like 1 in 30,000. Current thinking is that it's caused by a problem with the subclavian artery way back in the 6th week of development. You get that classic absence of the sternal head of the pec major, maybe some missing costal cartilages, breast hypoplasia, and often some hand anomalies as well.
So when do you operate on those?
Well, if there are missing ribs, that's a surgical indication. And for women, if there's significant breast asymmetry, you might consider surgery. But usually, we wait until after puberty for females to let everything develop fully.
And what are your options there?
Latissimus dorsi flap with an implant is a common approach. You can also reposition the insertion of the latissimus. And then there are alloplastic materials, meshes, silicone molds. Those can be useful as well.
All right, then you've got your depression deformities, pectus excavatum.
That's the most common one. See in about 1 in 400 kids. Boys are much more likely to have it. Seems to run in families, and it's often associated with things like scoliosis, Marfan syndrome, congenital heart disease. Basically, those lower costal cartilages grow too much, pushing the sternum inward.
And it gets worse with age, right?
Yeah, yeah. And it can actually cause some breathing and heart problems in some cases. So we operate for cosmesis for sure, but also if there are documented cardiopulmonary issues. And there's growing support for early repair. Well, those self-image issues can be tough for kids. And the best results seem to be when you operate between ages 2 and 5.
And surgically, how do you fix it?
Lots of techniques. The Ravitch procedure involves resecting those overgrown cartilages and repositioning the sternum. The nose procedure is minimally invasive. You put these curved steel bars in to reshape the chest. There's also sternal turnover, silastic mold implantation, lots of options.
And finally, the protrusion deformities, pectus carinatum.
Much less common than excavatum. Again, more common in boys, often runs in families, and you often see it with scoliosis or congenital heart disease. Basically, the sternum and costal cartilages stick out instead of in.
So the opposite of excavatum.
Exactly. And it's usually not noticeable until after age 10 or so. Rarely causes any functional problems, so it's mostly about appearance.
And surgically, similar to excavatum.
Very similar. You might resect some cartilage, reposition the sternum, maybe use a strut for support. Lots of overlap with the excavatum techniques.
All right, that's a lot of chest wall. Key takeaways for anyone prepping for the FRCS, what are the absolute must-knows?
Number 1, history and physical exam are everything. You've got to know about those prior surgeries, any comorbidities. Number 2, when it comes to infected sternal wounds, aggressive debridement is key. Get that hardware out, get all the dead tissue out.
And reconstruction, when do we do it? When can we avoid it?
For skeletal reconstruction, think 4 ribs or 5 centimeters. Or if the patient's got significant lung problems, even a smaller defect might need fixing. Posterior defects, prior radiation clamp, those can sometimes change the game.
And our tools of choice.
Locoregional muscle flaps, those are your workhorses. And for those congenital deformities, remember, it's mostly about aesthetics. Function is usually okay.
Awesome. This was a rapid-fire review, but it should give everyone a good framework for their FRCS prep. Chest wall is complex, but if you break it down systematically, it's manageable. Keep studying. Good luck on those exams.
Absolutely, you've got this.